to be able to introduce our speaker for today, Dr. David Maah. Dr. Maah is a professor of pediatrics and division chief of pediatric endocrinology at Stanford University and the Lucile Packard Children's Hospital. He is the associate director of Stanford's Diabetes Research Center. I know we have a lot of students on today from public health, and you'll be interested to know that in addition to his MD degree, he also has a Ph.D. in epidemiology. He served in leadership roles for the International Society of Pediatric and Adolescent Diabetes, the American Diabetes Association's Professional Practice Committee, the Type 1 Exchange Steering Committee. His scholarly interest is improving care and preventing complications in people with type 1 diabetes. He is author or co-author of over 300 research publications. His multidisciplinary research has been funded by the JDRF, the NIH, the Helmsley Charitable Trust, and the National Science Foundation. I have seen it as a career privilege to be able to work with Dr. Maah on the Echo Diabetes program. We thank him for his time today, and I'm going to turn it over to him.
Thank you, Ashby. Thanks for the kind words and introduction. And can you see my screen okay? Okay, good. Maybe move this up here like that. Okay, well, I will go ahead and get started, just have some disclosures. And I think probably the only one that's pertinent for part of this talk is that when I explain our new onset pilot program, the CGM supplies for the first month were donated by Dexcom. What I'm not going to talk about is the Project Echo, and we've had the pleasure of working with Mike and Ashby for the last, 2.5 years, I think, and thank the Helmsley Charitable Trust for that. And we've got a lot of people at both institutions that are working on this project. It's really been a pleasure to work with the Florida team, and we hope to have some results, more results to show people in the next year or two. So just as far as a bit of an outline, what I'm going to talk about is a little bit on the background on hemoglobin A1c in pediatric type 1 diabetes, some data from the type 1 diabetes exchange, some international comparisons that we've done with the T1D exchange, and then talk a little bit about technology disparities. Then I'm going to try to shift gears and go into what we're trying to do locally to try to improve outcomes for our patients with type 1 diabetes, and then back a little bit more nationally on some at least preliminary data from the type 1 diabetes exchange quality improvement initiative, which you are a part of as well. So just, I'm sure everyone or most people on this Zoom have heard about the type 1 diabetes exchange, but just briefly, it was established in 2010, a grant from the Helmsley Charitable Trust. It was formed to fill a need for clinical, translational, and epidemiologic research in type 1 diabetes and in the US. And there were 3 complementary parts supported by a statistical resource center with Roy Beck and the JABE Center. There was a network of adult and pediatric diabetes clinics. There's the GLUE website, and then also a biobank. Has been and continues to be an incredibly productive collaboration nationally. Over 94 publications, 168 presentations. Put the website in there and you can go and look. There's also data sets that are available. Ashby, if you've got public health students and someone's looking for a great data set, lots of data. And so just have to thank everyone, the 80+ clinical centers, hundreds of clinical investigators and research teams, 25,000+ participants, the JABE Center and the Helmsley Trust for the funding. And so basically all the data shown on the T1D exchange is thanks to this wonderful collaboration. So one of the big challenges with a national research group like that is how do we get better glucose control? And so I'm going to show you some of the data that we've got, some longitudinal data, focused more on children and adolescents and young adults and the international comparisons, as I mentioned. So I think everyone's really tired of seeing this slide. This is a great a slide that Kelly Miller and others put together, and these were data from the T1D exchange, and it looked at what were the A1Cs across the lifespan in from the ages of about 2 to about 80. And you can see where we have the ADA cutoffs here. At the time, it was 7.5% in pediatrics, then 7% in adults. And A1C much higher than we'd like it to be, and particularly higher in the children, adolescents, and the young adults. And remember, this is at the time about 20 years after the DCCT, when it was conclusively shown, and we understand very well the benefits of having an A1C at 7 as compared to 9%, as far as the risk of reducing complications in the future. So we've done a number of comparisons with international colleagues, and this is just one of them. This is 8 different countries, and you can see we just looked at what the A1C is, and it was raw and then adjusted for a variety of factors. But either way you look at it, the US was at the wrong end of the scale here. And also note that very similar to England and Wales and their audit that they do of their pediatric diabetes clinics. And this is just another way of looking at it. Again, what are the averages, but also what's the variability across the different clinics. So you can see Sweden and Germany had very similar mean A1Cs across their pediatric diabetes clinic, but there was more variability in Germany as opposed to Sweden. So that might have implications if you had a national healthcare system on how you might address differences in A1C and how you might go about trying to get improvements across your country. So this is another look then where we just compared that same type of curve in the Kelly-Miller paper and compared that same curve to the DPV group. And DPV captures over 90% of their pediatric diabetes patients. The US data are from pediatric diabetes centers or adult diabetes centers like University of Florida Diabetes Institute or Stanford or Barbara Davis Center or other places like that. So the DPV data is much more population representative compared to the T1D exchange. And you can see that there's about a 1% gap throughout the pediatric age span. They also have that increase in adolescents as we have, but they're starting at a lower point with their younger children. So again, these international comparisons are meant to identify what are some things we could work on and what's working for other places. And I'll come back to that theme a little bit later in the talk as well. So always hard for me to come up with titles of talks, but this next one, A1C to infinity and beyond. So got the Buzz Lightyear here coming in. My teenage kids were impressed. I actually was able to animate something in PowerPoint when they saw me working on this last night. What this graph shows is in orange, that's the data from the 2010 to 2012 in the Miller paper. Unfortunately, what this blue line is, those are the data from 2016 to 18. And so unfortunately, we actually saw an increase in the A1C, particularly in the adolescent and young adults. So that was all very unfortunate. And next steps with that, and here's another graph from that paper that was published in DTT. Next steps were try to figure out what might be causing this. And so one way of looking at it in Nicole Foster's paper in DTT was to break down what were hemoglobin A1C in the children under 13, the adolescents, young adults 13 to 26, and then all adults above 26. And looked at what was the A1C if you were on MDI, and then if you were on pump only, if you were on CGM, and then if you were on pump plus CGM. And you can see that there was a progressive decrease, and especially with CGM use, as well as CGM plus pump use. So a next theme in the talk today is diabetes technology and disparities. And really the first paper that came out in the T1D exchange looking at this, and again, with some of these questions, you have to have a big enough data set to be able to look at some of the data in different ways. And this was a paper by Steve Willey and colleagues that came out in 2015. And what Steve and colleagues did was, again, looking at A1C in that 1 to less than 13-year-old age group, and then the 13 to 18-year-old age group, and then looked at A1C either by pump, multiple daily injections, or whether you were on a fixed dose. and then broke it down by race, ethnicity as well, whites, non-Hispanic blacks, and then Hispanics in the check bar. And you can see that across all of these different ways of delivering insulin in different age groups, that the Black population had the highest A1Cs of all these groups, and they were higher by around 1% in most of these age groups. Hispanics were a little bit higher. The other thing that in this Wiley paper, they're able to break down what were the effects at different SES, and I'll look at that a little bit more in the next paper. So one of the questions then was how to explain the increased A1C from 2010 to 12 to 2016, 18. What is the role of diabetes technology? What's the role of income, insurance, race, ethnicity? And so Kelly Miller put together a really nice set of analyses, very thoroughly working through each of these, looking at hemoglobin A1C across the lifespan with those same types of curves that we've seen. So again, one of the positive things is that we've seen an increase in the use of continuous glucose monitoring. And these are data from 2011 to 2018, from 6 to 38%. And then in this lower part of the panel, we've got that same data from the first part 2010 to 12 to 2016, 18 by the different age groups. So you see the biggest increases were in the under 6, and then a pretty good increase in the 6 to 13, and at the time, not quite as much in the adolescents. So now when Kelly broke things down in this paper, and this is just the first graph that we've seen, what is the A1C, and then looked at it by whether you were on MDI or pump user, and it was, you have a lower A1C across the lifespan if you're a pump user compared to multiple daily injections. Same in this panel for if you were a CGM user, you had a lower A1C than if you were not, and then broken down by whether you were on MDI, pump, MDI plus CGM, or pump plus CGM. So these panels on the left, then in this top left corner, again, breaking it down by reported income. And so the higher your income, the lower your A1C. Whether you had no insurance, state or federal insurance, or private insurance, if you had private insurance, you had the lowest A1C. Then among CGM users, depending on what your income category was, you had a lower A1C, the higher your income. Among CGM users, yes, no, and then the same thing among insurance, that the CGM users were lower no matter what their insurance status. Then in this, looking at A1C by whether you are Black, Hispanic or Latino, and white, non-Hispanic, and you can see that these differences are across the lifespan. Then if you break that down from no matter how you check your glucose, no matter how you deliver your insulin. So this is the group with no pump, no CGM, and you can see that these are shifted higher than in this group who has a pump, and then this group who has CGM. And then breaking down again by race, ethnicity, and also by SES, and you can, or excuse me, income. And the higher your income, the lower your A1C. But across all of these, we have the highest A1Cs in the self-reported Black population. And this is a fairly large sample size. There were 586 Black non-Hispanics, 1,000 Hispanic or Latinos, and then about a little under 9,000 non-Hispanic whites. So a next step then was to follow up on some of this data that Kelly had generated with a comparison with Germany and with the DPV group. And just to call out Reinhard Holl, who's been a wonderful collaborator and leads the DPV group in Germany. And so what we looked at, these are a little bit of complicated graphs, so I want to take a little bit of time to walk you through it. We've got the DPV data on the left. We've got the type 1 diabetes exchange data on the right. These light blue bars are the data from 2010 to 12. The purple bars are the 2016 to 2018. And so in this top panel, what we're looking at is what was the rate of pump use in DPV. And you can see that from the earlier to the later time period, there was an increase across all 5 different SES quintiles. And so we broke down the data within each registry by SES quintiles. And so one of the points here is there was an improvement from the earlier to the later time period, but there's not a whole lot of difference based on what your SES quintile is. And then when you look at the T1D exchange, again, we've got an improvement in the number of pump users from the early to the later period, but there's a dramatic difference. If you're in a lower SES quintile, you're much less likely to be on a pump than if you're in a higher SES quintile, and that's very much in contrast to DPV. This next row has the same type of data, but for CGM use. And you can see that there, in both cohorts, there was a dramatic increase from the earlier to the later period. But there wasn't, and there isn't that much of a difference by SES quintiles in DPV, but there's a pretty dramatic and a widening disparity in use of CGM when you look at the lowest versus the highest quintile in the T1D exchange. So how about hemoglobin A1c? So in Germany, when we look by the 5 different quintiles, there is a gradation. The higher your SES, the lower your hemoglobin A1c. And that difference, though, has actually diminished over time. That slope is a little bit less than it was previously. Whereas in the US, unfortunately, as I've shown you, the A1c actually went up, and it went up for all SES quintiles. But also that slope is increasing, and actually the difference between the highest and the lowest has gotten wider in that last decade. And then in the bottom, there was just what we did was adjustment for pump and CGM use, and it explains at least part of that difference in A1c in T1D exchange versus DPV. So there was a very nice editorial that accompanied this in Diabetes Care from Terry Lippman and Colin Hawks from CHOP. And what they called for was trying to have a more time for a paradigm shift in how we approach our patients with pediatric type 1 diabetes. And I think we're all very focused on trying to get glycemic control, avoid ketoacidosis, hypoglycemia, prevent long-term complications. We focus very much on the diabetes care visits, individual factors, but then there's some other really important concepts that we need to keep in mind as well, the social determinants of health. And there's a very nice review in the same issue of diabetes care, position statement from the ADA. Also, forces in society, structural racism, market forces, and then public policy. Health insurance, federal programs, value-based care, research funding, et cetera, that all play a part in pediatric type 1 diabetes care. And we really need to rethink how we go about providing the care.